Looking to calcium, 99% of body calcium is stored in bone, and only 1% is found in the extracellular fluid. Of that small portion, about half of it is bound to proteins or anions, while the other half is free or ionized. And it's this ionized form that's biologically active. Calcium is essential for bone formation, nerve transmission, enzymatic processes, and cardiac and muscular contraction, and maintaining stable calcium levels is therefore vital for life. When we measure total calcium, we are evaluating both the bound and ionized fractions together, and this test is commonly used to assess parathyroid function, calcium metabolism, and conditions like kidney disease or malignancy. Because albumin binds calcium, changes in albumin levels will directly affect total calcium levels. In fact, total calcium decreases by about zero point 0.8 milligrams for every 1 gram decrease in serum albumin. This is why interpreting calcium requires consideration of that protein. Calcium homeostasis is primarily regulated by three mechanisms. First, parathyroid hormone mobilizes calcium from bone and increases renal reabsorption. Second, active vitamin D increases intestinal absorption of dietary calcium. And third, calcitonin from the thyroid promotes bone formation and increases renal excretion. Hormones like estrogens, androgens, and even blood pH can also influence calcium levels. Importantly, calcium has an inverse relationship with phosphorus. When one rises, the other often falls. Calcium regulation depends on a delicate balance then of hormones. Vitamin D in its active form, 1,25-dihydroxycholecalciferol, promotes calcium absorption in the intestines. Parathyroid hormone, or PTH, regulates how much calcium is reabsorbed by the kidneys. PTH secretion increases when ionized calcium is low, and it's inhibited when calcium levels rise. Calcitonin produced by the thyroid has the opposite effect. It promotes bone formation and increases renal calcium excretion. Together, these hormones maintain tight control of serum calcium. And calcium reference ranges vary with age. In adults, the total calcium should be around 9 to 10 and a half, while ionized calcium is 4.5 to 5.6 milligrams per deciliter. Children and newborns naturally run slightly higher. And what's important to remember here is that only ionized calcium reflects the biologically active form, which means even if total calcium looks normal, patients with hypoalbuminemia may actually have low ionized calcium, which can lead to symptoms. The critical values for calcium are life-threatening. If total calcium drops below 6 or ionized below 2.2, patients can develop tetany, seizures, and cardiac arrest. On the other hand, very high calcium, above 13 or above 7 ionized, can cause severe complications like arrhythmias, kidney stones, and coma. So these thresholds are clear red flags in clinical practice. When would we consider to measure serum calcium? Well, if we're wanting to evaluate parathyroid function, calcium metabolism, and bone health. It's especially important for monitoring patients with renal failure, renal transplant, or even suspected malignancy. And we track calcium in patients with hyperparathyroidism or hypoparathyroidism, since disturbances in these glands strongly affect calcium levels. There are several factors that can interfere or alter calcium results. Diurnal variation means that levels naturally peak around 9 p.m. Low albumin falsely lowers total calcium since half of calcium is protein bound. Acidosis or low pH can increase ionized calcium while alkalosis decreases it. And many medications can alter the results. Even something as simple as leaving the tourniquet on too long can elevate calcium inappropriately. And so always interpret the results within clinical context. You need just a red tube or an SST tube to collect, and fasting is not required for calcium and for most of these things on your comprehensive metabolic panel. If you have hypercalcemia, the most common cause is hyperparathyroidism, followed by potentially malignancy, although there's lots of different other cause etiologies. Tumors can metastasize to bone or produce parathyroid hormone-like hormones. Other causes can be prolonged immobilization, vitamin D intoxication, granulomatous diseases like sarcoidosis or tuberculosis, and endocrine disorders like Addison's disease or even hyperthyroidism. Excess ingestion of calcium or antacid levels can also raise up calcium concentrations. And so we want to always connect findings with our clinical history. It presents typically with nonspecific symptoms like fatigue and weakness or lethargy. Kidney stones are classic complications as calcium can precipitate in the renal system. And patients may also develop abdominal pain, constipation, or nausea. Remember the mnemonic stones, bones, groans, and psychiatric overtones. Cardiovascular effects include bradycardia and arrhythmias, and in severe cases, cardiac arrest. Clinicians must act quickly to reduce calcium levels when they reach critical ranges. This is looking at kind of a clinical flowchart for evaluation of hypercalcemia. A useful clue is that hypercalcemia often accompanies hypophosphatemia due to their inverse relationship. Patients can also develop metastatic calcifications where calcium deposits into tissues like the pancreas, kidneys, or arteries. So recognizing some of these key associations is helpful in diagnostics and management. On the other hand, hypocalcemia has different causes. It could occur in hypoparathyroidism, renal failure, or vitamin D deficiency, also seen with hypophosphatemia, rickets, osteomalacia, and hypoalbuminemia. Acute causes could be pancreatitis, fat embolism, or even alkalosis. Because ionized calcium is the active form, patients may experience symptoms even if total calcium looks normal, especially in cases of low albumin. Clinically, hypocalcemia manifests as neuromuscular irritability. Patients may present with tetany, muscle cramps, or even tingling in lips and fingers. Severe cases can lead to seizures, laryngospasms, or cardiac arrhythmias. And a positive Chvostek's and Trousseau's sign are classic physical findings. Recognizing these early is crucial to prevent life-threatening complications. And I'll post maybe a video showing those two signs so you can see what they look like, how they manifest. Ionized calcium testing is not a part of any routine chemistry panel. It does have to be ordered separately. You would order this because it is a calcium that's unaffected by albumin levels, making it more reliable in certain patients. So when I'm looking at hyperparathyroidism, for instance, I'm going to check this value to see if calcium is actually excessively elevated. You'd use this also potentially for monitoring patients in surgery with organ transplants, or like I said before, with parathyroid disorders. And would be the best indicator of calcium status. When we come back, we will look at carbon dioxide content.